Now I invite our most awaited talk, Dr. Jayanshu Sengupta sir, for the surgical pulse in managing the corneal edema. And as we have ample of times, may I please request the hall managers not to interrupt him by clicking the button. Let him continue, as we are very much eager to learn the surgical pulse from him. Thank you so much. Sir, all yours.
Thanks, Shumana. It's a virtual extravaganza of cornea and related situations, all lovely presentations. And Aditi, Dr. Jayanta, they all just nailed it, including you, because you covered a very important aspect of it. Now, the question is, did I do it? It's not you, did I do it? The surgical pulse in managing the persistent corneal edema. Now, when we have a situation like this, a person presenting with a postoperative corneal edema, the first important aspect is clinical evaluation, which you and Jayanta and Aditi and Nivedita, you all stressed upon so importantly. At the same time, it is very important to check the other eye status for this particular patient. Once we have done that, probably from the surgeon's point of view, we need to reconstruct the surgery, need to reconstruct what had happened during the surgery, that is looking into the past. So a very important aspect will be checking the wound position. As you know, in these situations, when we have a persistent corneal edema, many a times the wound is very anteriorly placed. And as I always say, if the probe is anterior, if the wound is anterior, the probe is closer to the dome of the cornea. So the plane of working is much closer to that endothelium. And if you have to dip a lot, you stretch the wound, and that also gives rise to a higher risk of Detachment detachment. The second thing is to guesstimate the hardness of the cataract from the other eye. Usually they correlate unless it's an uniocular hard cataract. We have to have an idea about the preoperative cornea, having a look from the other eye also. We have to consider the risk factors as has been highlighted all throughout these different talks. And then we actually come to the reason why this person is having a postoperative corneal edema. Is this because of TAS? Is this a missed fused dystrophy? Is this a reactivation of viral infection? Is this a raised IOP? And so in all these things, we look for the other damages inside there, whether I have a rent, whether I have a nuclear drop, a lens placed on top of it, and things like that. If it is patient is coming from outside, I know myself if what I have done on the day of surgery, if it is my own case. So the next most important thing is the recovery time. How much time are we going to give if everything else is okay? What is the recovery? Say we do not identify any of this because the IOP is normal, the DM is in place, the infection is not there. It's just we have a hard cataract in a PXF with a diabetic on antiprostatic medicine. So what is the recovery time that we are going to give? And then what is the medical management, which you all highlighted so nicely? At the same time, we have to keep a close eye on the signs of recovery. As you can see, in the first situation, the cornea is not resolving, the edema is not resolving, but in the second, over a period of time, this cornea clears up. So maximally in cornea practices, we follow a gap of around 3 months before we say that the cornea is completely gone, before we will intervene for replacement therapy. So at this point of time, the most important thing that we do is, as everybody pointed out, is to see the HRT or the anterior segment OCT and see whether the detachment is in place. Now, if you find that it is not in place, it follows a different path. But if we have everything normal, then the question is, should we therapy? So the options that we have are either we can continue medical therapy, modify it according to the need, we can repose it if the detachment is displaced, and we can replace it. A need may arise for the replacement if we find that the endothelium is grossly damaged and it is not going to recover. But there should be a minimum time gap between the incidence and the final intervention, because the eye should recover, the blood aqueous barrier should be re-established, so that we do not land up with a good graft and a post-operative pseudophakic macular edema, post-operative macular edema, which affects the final vision. So once we have this, let us consider the reposition as we are going to talk about. Now, we have to have an idea about how much of the detachment is detached. So a single picture of the HRT is okay for us. It shows us that the detachment is not in place. But going through all the scans in both the planes is very important, because it gives us an idea in the XY plane what is the area of the cornea that is getting displaced and that is damaged. And it is very important to jot down the area that we are intending to we are aware of that this portion of the cornea is affected. And at the same time, in certain sections we can see the wound, whether the wound is involved in whether the detachment is stripping from the wound or is it away from the wound, and things like that. So we get an idea about how far the DM is detached, what is the area of the involvement, where it is located, and accordingly we can actually plan our interventional procedures. So regarding the intervention, but before we enter into the intervention, we just have to remember that if there is a disinsertion and if it's an inferior one, there is this redetach more frequently, because as the air bubble shifts upwards or the C3 effect shifts upward, the detachment tries to scroll back again. So there's an area of plane which is created and the aqua sips in, and we have a recurrence of detachment. If the DM falls, then the superior and the central ones are the easiest, because the air bubble has a natural tendency of moving upwards or hitting the dome of the cornea. If there are tears in the detachment, then we have to understand that this endothelium is going to heal by the cell sliding over the uncovered areas. So we need a very good reserve to heal in such situations. And if there is a rolls, we have to unfurl the DM, the scrolls, and then we can ourselves introduce the risk of tears in such situations. So keep this in mind when we are actually handling these cases. And for the principles of reposition, we have to float it. Means if it is close to the iris, we just float it up back to the cornea. We have to unfurl it. If it is a scroll, we have to unfurl those folds. And finally, we have to use a tamponade, whether it is air, whether it is citrate, whether it is SFC, is mostly on the availability as well as on the extent, because you have to understand that air will disappear in 3 to 4 days time. So if I have a small detachment close to the wound, I may go in for air, but if I have a larger area, I would prefer a citrate or a SFC, which is going to stay in the eye for a slightly longer period of time. Now, a very important thing that we have to understand, that if this is a right-handed surgeon for a temporal phaco, and this is the right eye of the patient, we have the 4 quadrants of the eye. And now, if this is the quadrant which is affecting, so this is usually uncommon, because it is very difficult to reach that area. But it can happen if we use a bimanual or a Simcoe from the side port for the subincisional cortex. We may detach this part of the endothelium. Now, this part is mostly because of the temporal phacoprobe, because that is the area where we are approaching as a right-handed surgeon. That is our natural direction, because unless you have a very huge decubitus angle, you really cannot walk to the outside. So that is the area where we will have a natural tendency for doing our phacoemulsion. That is the area where we will have a detachment because of the phacoprobes. Now look into this area. This is the temporal. These 2 positions are because of the phacoprobe entry and IOL insertions, where we have where we are forcing things into, and this one is mostly because of the cross effect of the chopper that we are using, because our phacoprobe is going to the left and our chopper is going to the right, and if we are not careful, so this is the area where we will have a chopper induced injury. So if we see this lower nasal quadrant, it is mostly we will get the tears. If we go to the superior nasal quadrant, we will mostly have Detachment disinsertions falls from the phaco probe. If we have superior ones, we will have a incision related detachment detachment. So keep the, and this is a mirror image for the other eye, and this is a mirror image again if we are sitting superiorly for the surgery. So according to the surgeon's position, these things change, and it is very important to have a clear idea that moment you are seeing a DM detached or a stromal edema, try to localize it, and you know that probably something of this sort has happened, and it is very important to then actively look for the DM detachment. It won't be a normal postoperative corneal edema because you cannot access that area otherwise. And you have to understand that if there is an inferior DMD, a stage suture may be needed to keep the detachment straightened. Otherwise, it will always have a tendency to scroll up. Now, we will have a little bit of a case. As you see, we are sitting temporarily, and this is a detachment detachment which is happening obviously on the opposite side. So we can access away from that area. We inject the air bubble. We wait for some time. We fill the whole chamber with the air. And on the table, it is very important to see a portion of the cornea getting clearer before we leave before we pad up the eye for we patch the eye for the next postoperative checkup. Then we have this situation where we have again a situation where on left side of the cornea is involved along with the center. In such situations, we again approach it from the opposite side, that is the far end side. And sorry, just a second. We approach it from that side and we put in the air bubble. Now this is a central DM, but you see this the air bubble has gone down in size and it has been extending to the periphery. So that is why the fluid, as I said, makes a plane between the detachment and the stroma, and it tries to redetach repeatedly. So in those situations, it is very important to have a C3F8 sort of material. So in this situation, you put in the you inject the fluid so that you can unfurl, then you reduce the air bubble, then you replace it once more, you wait for it to you use the air bubble to unfurl the same way as we do in DSEC or DMEC, and then we tighten the chamber to the optimum pressure so that that remains attached. And in this situation, is always prudent to use a C3F8 or a combination of SFCs in a non-expansional mixture so that the patient is not that uncomfortable, and you have very good outcomes with such interventions. And now if you can see, this is a split which has taken place. A detachment has torn in a V, and in these situations also it is very important to unfurl and from both sides and replace the air or the C3F8 from either side so that you achieve. So take it as two separate cases of detachment when you are handling it, because one bubble from inferior side will probably unfurl the lowest arm of the V, and then you have another bubble from the upper side which is going to unfurl the upper part of the V. And this type of corneas, this type of detachment tears definitely require a very good endothelial reserve once it is apposed to heal, because these corneas heal with the help of endothelial sliding. So apart from that, we have definitely a situations where again the air bubble has reduced in size, and we need to again unfurl the tissue, stretch it out to the periphery, because this is the limbal disinsertion which has taken place from the instrument. So here you can make it out, we are sitting superiorly. Then you use the air bubble to iron out the detachment membrane or unfurl the scrolls of the detachment that is possibly over there. So because you have to understand that we do not really in the videos, it is not always possible to demonstrate that scroll, or because it's a two-dimensional image that we are getting, but on the microscope you have to have a very clear visibility, and it is very important to have use topical glycerin during this procedure or debride the epithelium to increase your visibility, because we need to be bang on, we need to not injure further in this situation. So we need to unfurl with the help of Sinski, with the help of spatulas, and then we let the air bubble grow in size, and after that we just try to put in more air bubble and make the chamber tight so that it stays over there. And it's very important that we secure all the wounds so that the post-operatively the chamber doesn't shallow, because if the chamber shallows, we are going to have the detachment fall again, and we have to take this patient up for the OT once more. So apart from this, there are certain situations where we have to replace the tissue. So it's a major shift from the full thickness keratoplasty. So that has made us less, probably we take it less lightly compared to our endophthalmitis or nucleus drop, because there people think that the vision is going to be permanently lost. But you have to understand, a permanent damage to the endothelium, though it can be replaced, is equally challenging and does alter the quality of life, or the post-operative can affect the post-operative outcome also in certain situations. So this is very important. We should not at any point of time ignore the importance of paying respect to the DM endothelial complex. And this is how it does. If whatever the situation is, either we have to replace the cornea, then we should be doing a good job. If we are reapposing the DM, then also we need to do it perfectly so that the final goal, that is the cornea, gets cleared and remains clear in the long run, so that the patient can enjoy a very good vision in the rest of his life. So the question, to conclude, we have to evaluate completely, which has been properly done throughout this IC. We have to plan properly, we have to time it appropriately, we have to select the options, we have to justify what we are choosing, and then we have to do the best. Thank you, Shumana, and rest all of you for your lovely talks, and Shumana for giving me this wonderful opportunity. Thank you.
We are so much lucky to be able to hear you, and it seems that it is like a Bible. It's like a Bible that we should go again and again to see and to learn. Excellent, sir. Just one question: that what is your threshold for doing triple in case of Fuchs?
Right now I have kept a threshold of 690 before I do a dissector. I'm still sharing? No. Okay. Yeah.
No. So,
Yeah.
yeah.
So see, I personally do not do a dissect triple or a demect triple unless I'm forced to do so. If I have a thickened cornea with epithelial scarring, I will go for a full thickness keratoplasty. If it is for a dissect, I want to give my IOL a chance, and my cutoff at this point of time is 690. Because you see, as we moved from 600 to 640, it was more so because of the improvement of the machines. The cornea did not start behaving better. It is just the machines became better, so we could move to 600 to 640. And now again, with the inclusion of all these advanced machines, the protections that we have, and all a better understanding, we can keep a really low flow system without compromising on the safety of the chamber. And so we can really go up. And also one point is equally important: if a patient is able to see less than what he is seeing, less than what is optimum vision, so long as that is a working vision, it is better to do that with your own cornea rather than have a changed cornea. That should be the dictum, because once changed, we cannot bring it back. So that is one of the reasons I do follow a higher grid.
Right, sir. Absolutely right.